Good afternoon and welcome. Thank you for joining us for EPA's webinar, 2020 Asthma Award Winners, Sharing Successful Strategies to Reduce School Absenteeism and Improve Health Outcomes. My name is Tracy Mitchell. I'm a registered respiratory therapist and certified asthma educator at EPA's Indoor Environments Division in Washington, D.C. I'm very excited and honored to be your facilitator for today's presentation. So again, welcome. So first, I'd just like to start off by congratulating our award-winning programs for 2020. Our first winner is Children's Hospital Colorado Breathing Institute out of Aurora, Colorado. You see their team photo there. And our second winner is the University of Texas Health Science Center at Tyler in Tyler, Texas. And you see their great team there in that photo. So congratulations to both of you. We're very excited to hear about your programs today. Specifically, our next slide, I'm going to introduce our speakers, our very esteemed speakers. From Children's Hospital Colorado, we have Dr. Monica Federico. She's the Asthma Medical Program Director. She graduated from University of Texas Southwestern Medical School and trained in pediatrics at Boston Children's Combined Residency Program. Dr. Federico did her pulmonary fellowship at the University of Colorado in Denver, and she began the asthma program in 2008 and has worked with a multidisciplinary team to build the current program that you're going to hear about today. She's joined by Melanie Gleason, who's a certified physician's assistant and is a senior instructor for the Department of Pediatrics and associate director for the school-centered asthma program at Children's Hospital Colorado. She's a member of CHCO's asthma team focusing on patients with high risk. As I said, our second winner, the University of Texas Health Science Center at Tyler, is represented by Dr. Paul Sharkey, who is the associate professor in pediatrics, Department of Allergy and Immunology. He's a board-certified pediatric allergy and immunologist, and he's been at UTHSCT since 1996. Beyond his full-time clinical work, he was the founding physician of the Breath of Life Mobile Asthma Unit, or Mobile Asthma Program, which was founded in 1998. And it was motivated by the death of a 10-year-old patient, which we're going to hear about that. Dr. Sharkey will be co-presenting with Dr. Michelle Bosworth, who has been at UT Health Science Center Tyler since 2009. She currently serves as the Executive Director of the Center for Population Health Analytics and Quality Advancement for the School of Community and Rural Health. She is board certified in both family medicine and clinical informatics, and previously served as the Chief Quality Officer and Chief Medical Officer. So as you can see, we have a wonderful panel of esteemed speakers with a lot of great experience and information to share today. So regardless of what organization you represent, I assure you that we have a lot of interesting and useful information. So what you'll hear from these two well-established programs today is how they each have used continuous improvement to evolve, grow, and sustain their programs over the years. You'll learn about their different approaches, but equally successful strategies for providing education and in-home tailored environmental interventions. You'll see how high-performing collaborations and partnerships, as well as strong leadership, are keys to both program successes. And you'll understand how data usage and data collection is essential to measure program outcomes. I'd just like to take a moment to talk about EPA's National Environmental Leadership Award in Asthma Management. This award remains the highest recognition that an asthma program can receive for its leaders, and it's about programs and leadership for delivering excellent environmental asthma management. Through a two-tiered competitive process, applicants are judged against the published criteria and chosen by a panel of experts representing government agencies, nonprofit organizations, and previous winners. So this is EPA's award, but we come to consensus on the winners. Winners demonstrate best practices in comprehensive asthma management based on the current guidelines And these programs deliver comprehensive care by coordinating housing, public health, environmental, and clinical care services. EPA is pleased to be able to shine a spotlight on these best practices in order to accelerate their adoption in other programs across the country. So EPA's award program started in 2005, and like AsthmaCare, it has evolved over the past 15 years. This year's winners join a total of 48 programs across the country who are previous winners and who have all had great success in having impacts, health impacts, and quality of life impacts in asthma management in their communities. I encourage you to visit the Hall of Fame on Asthma Community Network to learn more about today's winners as well as all of our previous winners, as you can see there throughout the country, notated by the stars. Lastly, I'd just like to take a moment to talk about EPA's role in asthma management. I think we all know asthma remains an important public health challenge characterized by disparities. There's strong evidence the current national guidelines that recognize the role of environmental triggers and their remediation as an important part of comprehensive asthma management. We know that Americans spend about 90% of their time indoors, and that's certainly been the case over the past several months with the COVID crisis. We also know that eliminating common indoor triggers like tobacco smoke, pet dander, molds, cockroaches, and dust mites results in decreased symptoms and asthma episodes and improved outcomes for people with asthma, especially those living in urban areas with substandard housing. We also know asthma is an expensive disease, costing the U.S. over $50 billion each year, and Medicaid spends more than $10 billion annually to treat asthma in children and adults. EPA supports the widespread delivery of in-home environmental asthma interventions because we know it reduces healthcare costs, increases savings, and expands the healthcare workforce. Home visits, often conducted by a community health worker or lay educator, are effective, particularly in high-risk populations. And today you'll hear how community health workers are important team members in both programs. As the technical experts on the built environment and health, EPA continues to lead federal efforts through non-regulatory strategies that enable communities to deliver and sustain in-home environmental asthma care aimed at assuring access, and we remain committed to that end. So with that, I'd like to now turn it over to our first speaker. Welcome, Dr. Monica Federico from Children's Hospital, Colorado.
Thank you so much. Hello. I just want to thank everyone for the opportunity to present our program. We are incredibly honored and humbled to accept this award and to be here with this amazing program from Tyler, Texas. My name is Monica Federico. I am an associate professor of pediatrics at the University of Colorado School of Medicine and in the Department of Pediatric Pulmonary Medicine. And for the last 12 years, I've been the medical director of the asthma program at Children's Hospital, Colorado. I'll be presenting with Melanie Gleason, who is the director of our school-centered asthma program. The mission of our asthma program is to provide excellent evidence-based care to children and to all the families and children with asthma and coordinate asthma care with our health system, including facilitated transitions of care between primary care providers, specialists, and community partners to achieve the best outcomes for children with asthma. At Children's Hospital Colorado, asthma patients, like in most other systems, are seen throughout the continuum of care. In this graphic, the larger words demonstrate places that see more patients, such as our general pediatric clinic, the child health clinic. Specialty clinics, including pulmonary and allergy, also see asthma patients, but we see them throughout the hospital, which led to our need and our interest in making sure that those patients and families are supported in our four walls and outside. So on average, our patients are mostly school age. They're about 40% Latino and about 15% African American. And in the outpatient setting, they're about 20% Spanish speaking. In this graphic, you can see that about 55% of the inpatients seen with asthma are insured by Medicaid, and about the same in the outpatient pulmonary are insured by Medicaid. This is significantly higher than the general population seen in both settings, and reflective of the under-resourced and overburdened population that we see with asthma. In an effort to address this and take care of these children and their families, we have created a comprehensive program. We have asthma champions in primary care, specialty care, inpatient, and emergency department care who help us deliver high-quality, evidence-based care using quality improvement methods and regular data reports. We work with care coordination to facilitate transitions and have outreach and community programming that provides education and support for providers, community-based caregivers, and families of children with asthma. Research throughout this system helps us assure that we are implementing the most recent best practices in this care. So the keys for our high quality are standardizing communication and standardizing care. We have worked across clinics, disciplines, providers, and hospital care to create a standard pathway for asthma care. Thank you. We have also worked with Health Teamworks to create a Colorado clinical asthma guideline that was created in 2012. In 2008, in concert with the American Lung Association, we were able to put together an educational conference to help support asthma education certification and to try to align messages and practices for kids with asthma across our systems. Finally, we have worked with other systems, including our clinically integrated network, which is the Pediatric Care Network, Denver Health Medical Center, which is another large system in our area and a federally qualified health system, and Kaiser Permanente to try to align our care, align our messages, and make sure as kids move from system to system, they are getting the same care and hearing the same messages. We have tried to allocate resources in our program to the most severe patients and those with the most difficult to control asthma. Using this system, we were able to create a multidisciplinary clinic for severe asthma and implement social determinants of health screening that includes navigator and social work support for those who identify barriers to care. Our risk stratification system is aligned with the hospital's risk stratification guidelines for patients. The hospital data from our program shows that we have been successful. You can see here that our inpatient and ED outcomes are better than other populations seen at the hospital, and when compared and benchmarked across the country, they are better than other children's hospitals seeing asthma. Our emergency department admit rate is very low at 19%. That's down about 10% from 10 years ago. In the emergency department, we only see a 1% revisit rate in 7 days, and in the inpatient, we only see a 1.3% readmission rate in 30 days. In the outpatient setting, and specifically in our pediatric clinically integrated network, we have been able also to gather data using a registry that was created in 2008. This is preliminary data, but as you can see, by standardizing care and by following outcomes, we're able to see decreases in ED visits and hospitalizations in the Medicaid and the contract population. On the y-axis here, you see the patient days, and on the x-axis, you can see time. The blue line here is the Medicaid population and a significant decrease in ED visits. The orange line is the contract population. Below that, you see a green line that shows significant decreases in ED visits for asthma in the Medicaid hospitalizations for in the Medicaid population, and the purple is the decrease in hospitalizations, all of which are significant and have been sustained over time. In 2012, we decided to dig deeper into our data and really see if we were getting the results we hoped for, specifically in the highest risk population. We conducted a needs assessment of kids who had been in the emergency department 2 or more times or in the hospital 1 time in the last 12 months. We found that these kids had different demographics than the overall population at 80% Medicaid and about 50% Latino, which is up about 30% from the baseline demographics. We also found that they were significantly under-resourced and reported significant barriers that we learned were specific to the families and really difficult to impact in a clinic setting. When we looked at our data, we learned that these visits to a specialty clinic, which is part of the high-risk program, did not decrease the risk of returning to the emergency department or hospital in the next 12 months. So we decided to take our programs to the families, and we partnered with many organizations to do so, including the Colorado Department of Public Health and the Environment, which funds much of the work, and with the Environmental Protection Agency, Region 8. So the Just Keep Breathing Asthma Home Visit Program is an asthma home visit program that was started in 2016 with funding from the Colorado Department of Public Health and the Environment. Our team includes the two women you can see in one in a red shirt and one in a blue shirt in this picture. Those are our most important community health workers without whom this program could not happen. We have a medical director, which is me, a program manager who makes sure we get all this right and manages all of our budgets, and a full-time nurse who is the clinical support to the community health workers and to the families while they're participating in the program. The program is targeted at children who have difficult to control asthma and who have been seen in the ED or the hospital despite specialty care or despite outreach asthma care. Children are eligible if they are 2 to 17 years old, if they live within 20 miles of campus, and if they speak English or Spanish. And of note, both Elsie and Carmen, again pictured here, are bilingual. What happens during these home visits? Well, over the course of 3 to 5 home visits that take about 5 to 6 months, we are able, in the first visit, conducted by a nurse and community health worker, to evaluate where they are from their asthma care, whether the family understands the medications, and whether they have the medications and tools that they need. In the 2nd through 5th home visits, the community health workers lead those visits and tailor their interventions and their education and anything else they do for those families to the family and their need. We're able to provide asthma education and barrier identification. And at the 2nd visit, we do a home environmental assessment. That home environmental assessment is performed using a tool that was created in collaboration with the EPA Region 8, Denver Public Health and the Environment, Fort Collins Healthy Home Program, and Housing and Urban Development. The home remediation tools come from our grant, and they also come from partnerships with these organizations and others in the community. So as we help the families with cleaning and organizations, we are able to provide them with recipes for kids-safe and cheap cleaning products. These recipes came from the Fort Collins Healthy Homes Project. And our first nurse in the program created this sort of ingenious pencil box, which costs about 99 cents. And we are able to create these color-coded pictorial graphics to show families what medications to use in the morning and what medications to use in the evening. For some families, we provide them calendars to track doses. And for some families who are able to figure out how to work with the system, we've been able to use electronic monitoring for medication adherence. For further environmental remediation, thanks to the Colorado Department of Public Health and the Environment, we have been able to provide HEPA vacuum cleaners, which you can see can do miracles, even in families where there is significant problems with previous infestations or with current pets. And we were sent by one of our families these beautiful pictures. We are also able to provide HEPA filters, and one family said that the purifier is working so well, we are no longer experiencing smoke from the neighbors while we are in our home. For more intensive interventions, we have been able to provide pest extermination, mold remediation, furnace filters, pipe foam, caulking, and even in collaboration with Energy Outreach Colorado, roof repair. Who does the program serve? At this point, we have served over 75 families. Preliminary demographics show that we see school-age kids, Most of them are male. It is about 80% Medicaid, as I mentioned previously, about 13% African American. And I will tell you that about 40% of these in 40% of these families, the primary caregiver is Spanish speaking. This graphic shows the results of our first 2 years of home visits. We completed home visits in about 94% of the enrolled participants, and in 49 patients who had completed the program and had 6 months of data, we found significant decreases in the ED and hospital visits compared to the 6 months before the home visit program. What makes us so successful? Well, during those home visits, we were able to work with families to manage their own asthma and to identify barriers. We were able to help them address barriers in their environment in 25% of the families, help them with language barriers in 22.4% of those families, and in almost 25% of the families, we really tried to help the families manage the chaos of taking care of chronic disease in children, and while also taking care of the rest of the family, especially in these under-resourced and overburdened families. We saw a 55% increase in adherence during this time and a 40% increase in the understanding of how to manage asthma, how to manage asthma exacerbations and medications over the 5 visits. We also have seen that the impact is sustained. This slide shows that compared to a similar population of kids who were not able to enroll in the program, those enrolled in Just Keep Breathing had a significant decrease in their utilization seen on the y-axis compared to the blue boxes, which is the comparison group. They had a more significant decrease in utilization in the 6 months after completing the program. And our patients and providers are happy. Quotes include, "I want to make sure that I'm giving Naomi the proper care, and this program allows me to do that." They've also increased Naomi's knowledge because we work with the children at every visit as well, and confidence. Having asthma isn't quite as scary anymore. And then the program helped me better manage my patient's asthma and helped both of us come together to control it. The patient is now able to play sports without any complications and does not need to use albuterol as often as he used to. That's a quote from one of our providers. I will now turn it over to Melanie, who will talk to you about the school-centered asthma program.
Thank you, Monica. Good afternoon to everyone, and thank you so much for joining us today. So as Monica said, we are deeply grateful to the EPA for acknowledging our program, and it is my pleasure and honor to share with you the school-centered asthma program. So I really think the success comes from the people, the relationships, and the partnerships that we have built. And so this slide shows our AsthmaComp team, who are photoed here to the left, and also Arthur McFarland, who is our program analyst and evaluator. I'm going to really focus on the asthma counselors and school nurse partnership in slides to come. So the one person that I really want to acknowledge on this is Dr. Stan Zeffler, who is centered there, who's in the center of the photograph at the left there. He is the one who is the visionary behind this program, has shown tremendous leadership and support for all of us over the last 12 years. As you can see, we also have a robust list of partnerships and very high-performing groups and teams that we work with. And lastly, I want to make sure that we acknowledge that we have had tremendous funding from the Colorado Department of Public Health and Environment. This is the history of our program and how we came to be AsthmaComp. So we first established the program in 2006 with the Colorado Step Up Asthma Program. It is an asthma counselor-led program that focuses on evidence-based education, including open airways for schools for children. We also work with school nurses and healthcare professionals in the school. In 2012, we established the Building Bridges program, which is school nurse-led, and it is a comprehensive asthma care coordination program focusing on linkage to healthcare providers. And so with our latest iteration in 2018, we wanted to have a unified approach and to have the asthma counselors and school nurses working together to identify students with the most needs and make sure that we have the right resources to address all of their needs. This is a map of the districts in Colorado and shows who we are working with. So the brown area there with the, in the middle, the metropolitan area, we work with 6 districts, and that includes 331 schools. Because we only have the 4 asthma counselors, we had to target schools that had the most severe asthma, highest asthma prevalence, and healthcare disparities. And you can see from the demographics of the participants who enrolled in the program that we are really meeting those with the highest need. We've also have expanded in the last 2 years to the other regions in Colorado, the North Central, Southeast, Southwest, West Central, and currently we're also working with the Northwest. And we coordinate this through the Colorado Department of Education Regional Nurse Specialist. Okay, as I mentioned, this is a really comprehensive program, and so I just wanted to highlight a few of our key components. So we really start with the basics, building the partnerships and capacity in the school community. We implement the evidence-based asthma management programs. We have a TA assistance programs for those districts who want to get started, and a continuous evaluation program for quality improvement. Our more innovative components include the Asthma Medical Neighborhood, and our goal is to provide a circle of support around these children with high-risk asthma. So we have the asthma health navigators, school nurses, engaged families, and supportive healthcare providers to do just that. We've also have a lot of team members who are innovative, and including Denver Public Schools, who we work closely with to develop powerful tools such as the Asthma Tab that can help school nurses identify who has asthma, track and monitor how they're doing over the school year, and use a dashboard to know when they should intervene with students. The telehealth visits Monica will address in our final slide. This slide I love. These are the people that I've been working with for the past 12 years that we've had our program. And they are the asthma counselors and also school nurses represented here. I'm going to introduce them as we go across. So our first counselor, who started in 2006, is Christina Colmenero. Next, we had Maria Bracamontes and Marianne Ceballos join us soon afterwards. And then Sheila Morgan, pictured over to the right. She has been our asthma counselor that joined us in 2012. So our team has been together for a long time. They are very high functioning, and they are the heart of the program. Together with the school nurses, they are the ones that are on the front line, reach the school students and families, and make the important connections. Just very briefly, each of the asthma counselors serve 10 schools each, and they enroll approximately 40 to 50 students each that they follow. They implement the comprehensive asthma care program, and very similar to what Monica had shown for those who are for the community health workers in the home. This is a screenshot of that asthma tab that I was talking about. And so at the beginning of the school year, if parents register online, they complete an asthma intake form that tells us about how their children did in the previous year before enrolling into the school program. And so it tells us if they've had hospitalizations, emergency room visits, if their asthma is controlled or not. And that automatically gets populated into the asthma tab. From that, the school nurses are able to pull both school level and district level reports so that they can identify who are the kids with the highest risk asthma and need early intervention. It also is a way that you could look at the school district, identify hotspots, and coordinate with other programs. Okay, this is our environmental strategy. So just as important as it is to reduce triggers in the home, it's also very important to reduce triggers in the schools where children spend up to a third of their day. So we watched a lot of the EPA webinars and we adopted the EPA IAQ Tools for Schools program. We have implemented this in the Denver Public Schools, primarily with the schools that we work with our school-based asthma program. But DPS was very enthused about getting more kids in school and keeping them healthy, so they integrated the indoor air quality in their 2020 Healthy Schools strategy. I also wanted to point out that in 2014, DPS was recognized for their work with keeping indoor air quality by the regional EPA. We are focused on the indoor air quality, and a very innovative program in Denver called Love My Air is focused on outdoor air quality. They overlap with many of the schools that our program is in, and so we are able to share information and to try to really support students who have asthma the best that we can. So this is a slide that shows just some of the impacts that we have had over the years that we've worked with the schools. The schools themselves and their districts have adopted asthma best practices, including some of the tools like the asthma intake form and the asthma tab. We've increased asthma care plans and access to quick relief medications. When we first started the program, 10% or less of the students had access to this. And over time, it has improved to over 65% in all schools that we work with. And for those who are enrolled in the asthma or in the step-up program, it's as high as 95%. We've also improved asthma care skills. The asthma counselors meet with the students 4 to 6 times over a 12-month period. During those visits, they do assessment of asthma skills, including how to use their inhaler, and they repeat that at each visit. And we have seen the scores go up over time. Sometimes during the summer, they have a little bit of a drop in their skills, and then they pick right back up. We've also seen improved adherence with controller medications, and that is really directly due to the counselors working with the families, identifying what barriers they have and helping them to understand the medications and what they're used for. So all of those behavior changes and practice changes have resulted in very good improvements in their health outcomes. These are results from our Step Up Asthma program, and it shows that we have been able to successfully reduce hospitalizations. The year before enrollment, it was approximately 11% of students enrolled in the program who had been hospitalized. And after participating in the program, that went down to about 3%. The same was seen for emergency room visits with a decrease there. Those students who have controlled asthma based on their asthma control test in the 4 weeks prior to the assessment showed that more children had controlled asthma following their participation. We also have children who are more active and fewer activity limitations. The last point on here is impact on grades, and this is based on parental report. So we show that after participation in our program, the parents and caregivers felt that their students had less of an impact on their grades. And finally, our outcome, and the one that we share with school districts, is really making sure that children are in school and ready to learn. So our primary outcome measure for the Building Bridges program was to reduce school absences. And this was a study that was performed, and it was actually sponsored by GSK. It was performed both in Denver, Colorado, and Hartford, Connecticut. And what this demonstrates is that children who have asthma with at-risk features and participated in the program had fewer days that they were absent from school due to asthma compared to students with the same severity matched for controls. So this was a tremendous outcome measure for us, and we are really excited about it. The schools have been super in their support for us and welcoming the program. So just as in the schools, we also want to reach out to other members of the community And through our Reach the Peak Asthma Educator course, which this would have been the 13th year, but unfortunately, due to the COVID crisis, we had to cancel that particular course for the year. And we're looking forward to doing it either in person or virtually next year. So we have helped hundreds of asthma counselors, respiratory therapists, school nurses, and other healthcare providers become certified asthma educators. We also have a team of people in the Breathing Institute asthma program who love to volunteer for camps, including the Roundup River Ranch. And it is a very fun team to work with, and it's all about teams. So we support each other in all of the ventures that we undertake. This latest was the Back to School Asthma Education Olympics that Bridget Raleigh started, and it was performed both on our campus in Aurora as well as our Colorado Springs site. And so the kids and the families had lots of fun, and we're looking forward to doing that year after year. We also help support other health fairs throughout the community. I believe that is my last slide, and I'll turn it back over to Monica. So thank you again very much for your time.
Thank you. In the interest of giving the rest of the time to Tyler, I'll just say we've tried to move our care and many of these programs to telehealth, and we can answer questions about that in the question and answer period. Thank you guys very much for your time and for this award.
Thank you, Dr. Federico. I appreciate that. You have a really unbelievably comprehensive program, so thank you for those presentations. So I'd like to turn it over now to Dr. Michelle Bosworth from University of Texas Health Science Center at Tyler.
Thank you so much. Good afternoon, everyone. That was a really hard act to follow. Congratulations, Dr. Federico and Melanie, on really having an amazing program. I'm Dr. Michelle Bosworth, a family physician who'll be presenting today with Dr. Paul Sharkey, an allergist immunologist, who is also our founding physician for the Breath of Life Mobile Pediatric Asthma Clinic. On behalf of UT Health Science Center Tyler, I would like to thank the EPA for being honored with this award. Dr. Sharkey, as our founding physician, will now tell the story of how our program began.
So anyway, I'd also like to say thank you so much for this honor, and it's amazing to be included with this incredible program we just heard about up in Colorado. That is truly a comprehensive and meeting asthma care at all levels. That was very impressive. Anyway, let me give you a little background on how our program came to be. So I started at UT in '96, and in 1998, I had a little boy in my clinic named Wesley, and he had the unfortunate circumstances that he had a single mom who didn't have transportation, so he got to clinic when she could get a ride, and he got his medicines at Barksdale Air Force Base, which is in Shreveport, about 2 hours away. And if she couldn't get a ride, he did not get medications. So during a period of time when he was without medications, he had a fatal asthma attack at home. It was just a truly tragic loss. I'd actually seen him in clinic 2 weeks before he died. He had an FEV1 of 75. His control at that time was pretty good. I'd even thrown some pass patterns to him out in the hallway with football when I had a little downtime between patients. So this came as quite a shock. And it was a tragic loss and one that should have been able to be prevented with appropriate measures in place. Well, later that fall, I was at my national meeting in San Diego, California, and I'm walking across the parking lot to try to find lunch, and I see a bus pulled over in the parking lot that appeared to be running a clinic. So I went over to check it out, and surely enough, that is what was going on. And the caregiver on the bus was one of the physicians that trained me during my allergy training program in Kansas City. So we set up dinner that night, and it was through those conversations that I became convinced that we needed to try to start a similar program in East Texas. So our program was intended, much like the Colorado and a lot of these great programs across the country, to try to circumvent a lot of the major obstacles that prevent effective asthma care, so stories like Wesley don't happen. And some of the major things that we identify are transportation, difficulty getting to visits like Wesley had, cost. A lot of people don't go to visits because of what they're going to have to pay. And then language can certainly be a big barrier, especially in Hispanic populations. And similar to Colorado, we have a large Hispanic population here in East Texas. So for those reasons, we never have a charge generated to anyone seen on the bus for any of our services, so money is never an issue. And we hold our clinics at schools, at apartment complexes, at boys and girls clubs, at local underserved medical clinics to help with the transportation issues. So we go to the patient rather than them having to come to us. And then we always have someone bilingual available, and so we can have help with Spanish. And in the cases where we have someone who speaks a different language, we've had people speak Burmese and Vietnamese and Chinese, and so when we get different languages, we have a language line that we can call and get a translator to help us work through the clinic visit. Our program was based on the principles and with a lot of help from the nationwide Breathmobile program, which was created by Craig Jones in inner city LA. In terms of funding for the program, we tried for years to find funding. So it was in 1998 that we got the first ideas that we wanted to start forward with this program. And we tried various grants and institutions and donors and were unsuccessful until 2007 when we got a grant sponsored in Congress by the Honorable Ralph Hall, and we received a HRSA grant for the appropriations for the bus. So we had appropriations for the bus, but not actually for staffing. So in the first several years of the program, we were only able to go out 1 day a week because that's how much the hospital would release us to go out free of charge. And so we were limited in the number of schools we could see. We started with one in a small town in Winona, just north of Tyler, close to where Wesley was from, and then we ended up with 8. And the initial team was just myself or another retired pediatrician in town. My secretary was our CHW, and my charge nurse in clinic was my asthma van nurse. And it wasn't until late 2013 that we received DSRIP funding. So DSRIP is Delivery System Reform Incentive Payment Program. It's part of the 1115 Medicaid waiver. And that funding allowed us to fund staffing and greatly expand our services. So in late 2013, 2014 is when we started going out 4 to 5 times a week, or 4 to 5 days weekly. It also allowed funding for a sister program in the very northeast corner of our state in Texarkana, based out of Christus St. Michael's Hospital. So combined, our two programs cover the majority of counties in East Texas. We're in 50 school districts, and we serve 19 counties. The services that we provide on the bus are the same services you would provide in any freestanding asthma clinic. So we follow the NHLBI guidelines and the updates for asthma diagnosis and treatment. We do allergy testing and use that information to help with adjusting our treatment plan and behavioral and lifestyle modification and allergen avoidance. We look for asthma comorbidities because, as everyone on this call knows, a lot of times it's not the intrinsic asthma, but it's the comorbidities like reflux or sinusitis or allergies or sleep or even obesity that contribute to the breathing difficulties. Everyone gets spirometry at every visit, and a lot of the visit on the bus has been in terms of patient and family education. Patient who has been given medication but doesn't really know how to do it or why to do it or when to do it is not going to have a good outcome. And so it's giving that information. My wife is an attorney, and she likes to say you are charged with knowledge. And it's empowering to these children once they understand what they're doing and why they're doing it and how they're doing it and how to do it appropriately. We get a lot more buy-in, and people do much better. In addition to direct asthma care, we will participate in asthma conferences or asthma fundraisers. And we do a lot of speaking engagement for nursing education and at different independent school districts. So this is our team. You can see we have 3 members that are on the bus full-time. That's Cindy, our LVN, on the left, Colton, our community health worker, in the middle, and Jennifer, our nurse practitioner, on the right. That's me hiding in the background. On the top right is Michelle, and she's our administrative supervisor, and she's just been a godsend to help our program. And then Brenda Lee in the bottom corner on the right is our statistician. So in terms of roles, our nurse spends a lot of time, she does spirometry, she does all the skin testing, she does a lot of the inhaler management and teaching on that. She does a lot of education with the families. Our community health worker, Colton, he's kind of the Renaissance man in that he does a little bit of everything, from scheduling to a lot of the intake into our EMR. Everyone is trained to help patients that are uninsured, direct them toward insurance, and if they don't have a PCP, particularly if they've been using the emergency room as a primary care treatment, directing them toward a PCP. He does basic maintenance on the bus, and through a generous grant from the Dallas EPA in 2018, he actually was able to be trained in indoor contamination assessments and has been going and doing home visits for us in our high-risk patients. We treat every patient that comes to the bus, whether they're high risk or underserved or not, but we try to target our visits to places that are documented to be underserved or to have high medical utilization, such as high ER rates or high hospitalization rates. All the data from I'm so sorry, I left out our nurse practitioner. She obviously takes the history, asks any additional questions, makes the assessment, and writes out a written treatment plan, and then goes through that plan and performs a lot of education. She's just done a fantastic job. So the treatment plan is copied. We give one to the family. If the family okays it, we give one to the school nurse. And then if we have a PCP that's identified, we'll generate a letter targeting what we did on that clinic visit that day.
The goal of our program is to really go beyond the traditional healthcare delivery model and bring care to patients while decreasing barriers to care. We are all aware of the huge impact that social factors have on health outcomes. Our program decreases some of these barriers, as Dr. Sharkey has just mentioned. The convenience of the bus really occurs because the bus pulls up in the school parking lot and the parent will go check out the child out of school and then just walk in the parking lot to the bus, have the visit with their child, and then returns their child to the school after the visit. This is all coordinated with the school nurse. This cuts down on time away from the classroom as well as the parents' time away from their jobs. Our program serves a vulnerable demographic, with 3/4 of our patients being either government-funded or self-pay, with just under half African American, a third Hispanic, and a quarter Caucasian. The UT bus, along with an expansion of our program with our partner Christus St. Michael in Texarkana, sees 2,500 visits annually. During our inaugural year, we went to 5 schools within 2 school districts in the Tyler, Texas area. And then 7 years later, as Dr. Sharkey mentioned, we were able to expand through the 1115 waiver. We had an opportunity to partner with Christus St. Michael, and this allowed us to create a second mobile asthma program to serve patients in the most northeastern region of the state of Texas. Collectively, as Dr. Sharkey has mentioned, we have now been able to reach 50 school districts in a 19-county region. This program wouldn't be possible without school nurses. To illustrate the heroic role of school nurses in the program, I've included Banksy's latest artwork that he produced and gifted to a hospital in the UK due to the heroic role of nurses during the COVID-19 pandemic. In this image, you can see that Batman and other childhood heroes have been placed in a wastebasket and replaced with a nurse. UT also holds school nurses with this high regard. Our mobile clinic's community health worker works very closely with these school nurses to identify children who have asthma and who would benefit from this program. Many of these children are identified by the school nurse due to missed school days, symptoms during school activities, and as being frequent flyers to their office during the school day. These school nurses know who these children are. The school nurses also send out asthma symptom questionnaires to parents to identify patients. Communities will also hear about our mobile programs through word of mouth, health fairs, community events, so self-referrals are always welcome in addition to physician referrals. The mobile program is important to Northeast Texas because of the disparity in disease burden in our region compared to the state. 14% of children in Northeast Texas have asthma, which is double when compared to the state prevalence of 7%. Northeast Texas is also mostly rural, has fewer primary care providers, and unfortunately has some of the worst health outcomes in the state due to higher smoking rates. And to top it off, we also have higher pollution, pollen, and mold exposures, making this especially difficult for asthma patients. I've already mentioned the demographic of our population served. However, a few more key details addressing disparity is that the majority of schools visited serve low-income students, with the respective counties having about 30% of their children living in poverty. Our African-American population served by the bus stays within that 40% range, and unfortunately, African-American children in Northeast Texas have 3 times the normal state rate for hospitalizations when compared to Caucasians and Hispanics. Dr. Sharkey will now speak about our approach to asthma care.
So as I mentioned earlier, we treat according to the NHLBI guidelines, the Expert Panel 3 report, and then the revisions that have come from that. We have an EHR template that helps guide the provider to deliver the standard of care. Our template was based off the AsthmaTrax electronic system developed by Lauren Clement and used widely throughout the National Breathmobile system. We use the template is used to help classify the patient in conjunction with the nurse practitioner. We'll get a level of severity or a level of control, and then we'll make treatment decisions based on that. Every patient gets spirometry and physical exam every visit. We perform skin testing usually on the second visit as an incentive to come back for your asthma van evaluation. We perform testing we assess testing for asthma control. We use the ACT test, which is a validated questionnaire for asthma control. We use the PACT for the younger children and the ACT for children 12 years of age and older. And then all that information is brought together to develop asthma action plans, which again are provided to the family, the school nurse on most occasions, and the pediatrician or family physician if one is identified. So what we do on our asthma action plans, or like any standard plan, we're going to have a section for these are the medications you take daily to help control or prevent your asthma. These are the medicines you're going to use to step up therapy when you get sick or when you're exposed to something that you know is going to trigger your asthma. These are your rescue medications used as needed. And then everyone's given an emergency plan and instructions on when to seek emergency care. So all of that takes a lot of education that I mentioned, talking about medications, the different environmental triggers, and we certainly use peak flow monitoring in certain patients to help them with asthma monitoring. In terms of our environmental services offered, every asthma van patient receives an environmental assessment and allergy testing on site that's free of charge. We evaluate 18 common seasonal and perennial allergens. Based on that information, then we can give avoidance information, or it can help the family with home remediation or even lifestyle changes. And if they're interested in immunotherapy, the patient will be requested to be evaluated by an allergist in their area. If they don't have one, they're always welcome to come to our institution and be evaluated through the allergy clinic. In addition to the regular allergy testing, we have a tobacco cessation grant. So in 2019, as part of an MD Anderson out of Houston and a UT Health Center CPRIT grant for tobacco cessation, our LVN began identifying patients who live in homes with tobacco users. So when those patients are identified, a second community health worker from the CPRIT grant comes to the van and does tobacco cessation counseling to the guardians of the affected asthma patients. And then those guardians can then enroll for free into an MD Anderson-sponsored tobacco cessation program. In 2018, again through that generous grant from the Dallas EPA, we were able to get our CHW trained in indoor contamination assessments. So we target patients, again, that are severe persistent, they're very poorly controlled, or they have a high medical utilization rate. And Colton will go into the home and do an environmental assessment. And then with that information, we can connect patients and families with key resources that they need to get the help that they need. We do a lot of teaching in avoidance. We can provide covers and filters. We can help direct toward extermination or with remediation if that is needed. And regardless of asthma severity, resource assessments occur on every asthma van patient at every visit. So I'm not going to really talk much about this slide other than to say these are some of the electronic templates that we use when we're assessing smoking, triggers, or home environment. And I apologize that that's so small and hard to read, but if anybody wanted larger copies, we could certainly get those provided to you. UT Health Center provides free pollen and mold counts to the East Texas community, so not just to the UT area. And we try to direct our patients to access this pollen and mold count information because many, if not most, of our asthmatic patients do have allergic triggers. And if they know those triggers and when they're elevated, that can help them successfully modify their care. So for example, we had a patient that had mold as a major trigger for his asthma. And in the spring and the fall, when we get a lot of rain and the mold counts get really high, if a patient knows that information, then he can decide, this is the day I'm going to really check my peak flows to watch them, or maybe to start step up or preventive meds when he goes outside, or maybe that's just a day he'll decide that he wants to hang out indoors a little more. So knowing this information can be very helpful for our patients. So this is our data from the first 2 years in the program. And what you can see is, again, we were initially at 5 schools and then 8 schools during this time frame. And in that time frame, we had 144 patients with the valuable data over a year. So we were able to assess kind of before the current levels of control. One of the things that we saw is that follow-up rates are poor. And this was seen at breathmobile programs all around the country unless they're able to incentivize patients to actually come for the visit. So what we did see is that there were no hospitalizations in any of the patients in this about a 1.5-year time frame that we're looking at here. In the Tyler schools, which were the majority of schools that we were at this point, 92% showed improved control, and by the second visit, 85% would be considered mild intermittent, or now they would be considered well-controlled asthmatics. However, at the Winona School north of town, we did not see that. We saw that control was more difficult to achieve, as you can see. About 40% improved, 40% stayed the same, and almost 20% got worse. And their levels of severity were higher also. In terms of the actual outcomes we looked at in the Tyler schools, we saw very good outcomes in terms of missed school day reductions, ER visit reductions from a baseline, a 4-fold decrease, and oral steroid bursts were dramatically decreased in those patients. We did not see the same in Winona, but we did see a huge decrease in hospitalizations in Winona. So from the year prior to being entered into the program, we had 9 hospitalizations in that group, and there were none in the first year in the program. And in missed school days, which is something we're certainly targeting, we saw a 3-fold decrease in missed school days. When we got our DSRIP money and we were first able to start expanding services, this data looks at that, and it looks at the first little over 1,100 unique patients that we're seeing. Certainly not all patients seen on the bus actually have asthma. A lot of people just show up with a history of cough, and they could have reflux or sinus disease or just allergic drainage. So of those 1,100 patients, 870 were diagnosed with asthma. 339 returned for follow-up, which was 39%. Again, when you're not able to incentivize patients or the schools, we had lower follow-up rates. And what was a little disappointing was that when we looked at one-year data, the people that were actually be able to see, okay, this is your data the year before to the data this year that you've been in the program, that knocked it down to 16% of patients. So a little over 140. So in terms of demographics of who we were seeing, you could see it's roughly 50-50, a little more males, about 40% African Americans, about 30% Caucasians and Hispanics. And very surprisingly, we found a lot of milder asthma. Over 70% were either classified as mild, intermittent, or severe. In terms of payer sources, 3/4 of the children that we saw had insurance, 26% did not. And of those that did have insurance, they were about 70% Medicaid. So typically more than you see in standard practices in hospitals. So in terms of the outcomes, there was a 50% reduction in emergency room visits. And if you did that as a per patient rate, they went down to about 0.55 ER visits per year. What was a little disappointing, though, is because the patients tended to be so mild, their baseline levels of missed school days and ER visits were actually quite a bit lower than we expected to find. So this is our data in the last 4 years. And again, we've tried to present this data as a per patient, the amount of events that occur per patient. So after being in the program for a year, the average patient missed about 1 day of school. After being in the program for a year, the average patient had between 0.3 and 0.5 oral steroid bursts a year. And actually, if you factor out 2019, which is the year that we got the 0.34 and the 0.5 and the 1.3, 2019, we had a lot of turnover in staffing on the bus, and there was about 4 to 5 months the bus did not even go out. So I think that kind of explains some of these higher data points. But certainly that's far below what is considered acceptable control for asthma. And then the emergency room visits, if you take out that one bad year, they're all between 0.17 and 2. So when you look at this compared to national benchmarks for similar programs, it's very comparable or even favorable in some circumstances. This is just looking at CDC data on missed school days per year. And here they report a very high 13.8 per year. I've seen other studies that have reported lower rates, but you can see at 1 missed school day per year, that's a dramatic decrease in patients that have active asthma. So anyway, that's going to conclude my portion of the speaking. I thank you for the opportunity.
Thanks, Dr. Sharkey. So one of our goals is that we really want to make sure that our patients are not solely reliant on the mobile asthma program as their primary care provider. Therefore, we either connect our patients into our own UT health providers, if geographically appropriate, or local care providers in the community. All of our UT Health Science Center Tyler primary care clinics are NCQA patient-centered medical homes. And our continual goal now and into the future is to really ensure that we continue the continuity with the primary care providers. Unfortunately, we all have been impacted by the COVID-19 pandemic. In response to the pandemic, our mobile program became immobile. We transitioned to telemedicine visits and were not able to see patients that were new because we weren't able to perform spirometry or allergy testing for diagnostic purposes. Just this morning, our bus actually underwent an occupational health evaluation with recommendations made from our occupational health department and residency program for the safe practices regarding infection prevention and PPE requirements for our patients and staff so that we can safely get our mobile program back up and running. Our program has had a diverse funding background, as Dr. Sharkey had mentioned initially, from a HRSA grant, philanthropic donations, and the 1115 waiver. Along with these, UC Health Science Center Tyler has been committed to the sustainability of our mobile programs. We want to continue to strengthen our partnerships with primary care providers as well as with the schools through the implementation of a school asthma management program. Additionally, we participated in a recent grant proposal with our UT system partners that will focus on strategic and risk-stratified scheduling of the mobile clinic visits. We look forward to continually improving health outcomes for pediatric patients in Northeast Texas. And thank you all so much for attending. And thank you again to the EPA for honoring us with this award.
Great, thank you. Thank you to all of our speakers. I think it's very easy to see why these two programs received this year's award. Again, congratulations to our two programs, and thank you for your participation today. That concludes today's webinar.